So, my name is Nick Nelson. I work at the Highland Hospital Human Rights Clinic at the county hospital here in Alameda County, just up the hill. Sorry. Was I just too far away? And first, I just want to thank the organizers for putting this incredibly important event together, particularly at this important moment in our national history. So I'm a general internist, and I'm going to speak specifically from the point of view of clinical care for migrants, refugees, and asylum seekers, talking to some extent about a few of the distinctions that have already been raised between refugees and migrants who don't have any status or documentation on arrival in the US. So the brief for my section is to address what practitioners need to think about when they're interacting with people who fall into these classifications. I'm not going to focus exclusively on torture, although it's most of what I do, but I would note, by way of framing the issue, that there's at least 3 observational studies in urban coastal primary care clinics demonstrating that the prevalence of torture among people who were born in the born outside of the United States with no other criteria applied is between 4 and 10%. And that includes people who were born in Sweden and France and whatever. So when you narrow it down to the people who we're talking about, it's going to be considerably higher than that. Not to mention less stringently defined forms of abuse and trauma like domestic violence, socioeconomic and ethnic persecution, and migration trauma, which are all definitely more common than that. So what I thought I'd do is just, because I'm a clinician, kind of tell some clinical stories about patients that we've seen in the Human Rights Clinic that crystallize aspects of physical health, mental health, and socioeconomic and legal health that are specifically relevant to these populations. So as an internist, the easiest place for me to start is with physical health. That's what I was trained to take care of. That's what I do best. And one of the things that came up kind of implicitly in Dr. Geltman's presentation is that people who are from other countries, by definition, are at risk of, are at differential risk of other health problems, mainly infectious diseases, right? And if you're a refugee, you receive some form of pre-departure screening before you leave, and after you arrive, there's a clearly developed infrastructure for providing health screening and health care. A lot of the people that we see at Highland walked here from wherever they started. The 2 most extreme examples of that I can give you, where we have 2 patients now. I thought this was a unique story, but we have 2 patients now who stowed away on freighters. Sorry, we're in Eritrea to begin with. We're forcibly conscripted, escaped forced military conscription, fled through Sudan to the Arabian Peninsula, where they then stowed away on freight ships to Latin America, and walked from, in one case, Ecuador, in the other case, Brazil, to Oakland, California, unable to read the Roman alphabet, let alone read English or Spanish or speak either, right? Speaking only Tigrinya. That's incredible, right? I mean, it's unimaginable. So in terms of physical health, not only do those 2 people have a higher risk of the things that they were at risk of just by virtue of being born and raised in Eritrea, which would include HIV, tuberculosis, intestinal parasitic infections like schistosomiasis, but now they've also walked from the Latin American tropics to Oakland and accrued a whole bunch of other different risks along the way, right? So these are things that, you know, like Dr. Gelman's program of refugee screening are designed to address, but the array of risks that people become exposed to is so diverse that even the CDC guidelines don't really cover them all, and clinicians working with these populations have to at least be aware of the absolute basics. So one clinical story that illustrates how important this is at Highland 2 years ago, we had a patient who was a Vietnamese immigrant who I don't think he had refugee status. I'm not sure if he was documented at all, but in any case, he had been resident in this country for about 20 years. He then developed a primary brain tumor and was treated with combination chemotherapy that included powerful immunosuppressant drugs. And then he developed a fulminant multi-system illness characterized by renal failure, respiratory failure, and a really bizarre rash, and no one could figure out what was wrong with him. He got biopsies of his rash, and he got a procedure called a bronchial alveolar lavage to look at fluid from his lungs. And on the same day, the results of both came back with whole worms that had been asymptomatically resident in his colon since he had been in Vietnam and had disseminated into his body when he was immunosuppressed. Now, and he died of this illness. This could have been prevented with a simple stool examination when he arrived, or at any time during the 10 or 20 years that he had been living in the U.S., or a blood test. So that's a really extreme thermonuclear example of why it's kind of important for this, for clinicians to be aware of this stuff. Another sort of more benign and recent one is that we just had an outbreak of trichinosis. Anybody remember trichinosis? I've never seen a case of this in my practice, right? So until recently, we had 8 cases from an extended social network who bought a feral piglet on eBay and raised it in their backyard for the New Year's celebration, right? And didn't cook it completely. So both by virtue of in-country exposure and by virtue of cultural practices, once people are here, there's a lot of medical stuff that we need to be aware of. And if people have further questions about screening of immigrants and refugees, I'd refer them to Dr. Geltman. So the other big aspect that I've had to learn about in the work in this clinic is mental health. And someone whose name I'm blanking on momentarily, but I think this is a great phrase, said that trauma is the great imitator in psychiatry. So in medicine, there's various diseases that we call the great imitator: tuberculosis, syphilis, because they can present like anything. Trauma can present with symptoms that are primarily anxiety, symptoms that are primarily depression, frank psychosis, and a huge variety of presentations that are rooted in individual idiosyncrasies and in the cultures of the individuals in whom they develop. So here's an extreme example of that. A couple of years ago, a middle-aged IT professional, originally from Yemen, who already had refugee status in the United States, came to our hospital, and he complained of a precipitous weight loss over the preceding 2 months of about 90 kilograms, which was substantiated by the presence of huge folds of redundant skin on his abdomen, and rectal pain. And those are his presenting complaints, right? So any general internist thinks, where's the tumor? This guy has metastatic cancer, it's probably colon cancer, where's the tumor? So he underwent probably a $500,000 workup, including endoscopy of his entire GI tract, CT scanning, with absolutely no result, and he was discharged with a diagnosis that wasn't even really a diagnosis. No one could figure out what was wrong. So a couple months later, he came back with an essentially identical presentation, and they did everything they hadn't done the first time and spent another $500,000 working this up, again with absolutely no result. He had 2 or 3 primary care visits after that where still no one could figure out what was going on, and then finally after someone in primary care actually asked him if he had been traumatized, but no one asked him if he had been tortured in those words at that visit. At the next visit, someone asked him specifically, have you ever been tortured? And that was when it turned out that 2 months prior to the initial presentation, he had gone back to Yemen to prosecute a dispute over some land his family owned with the government, and they had imprisoned him and tortured him in ways that are too horrible for me to describe in mixed company, or just any company, really. And that all of what he was experiencing represented the psychological residua of that torture. Incidentally, I saw him in clinic the other day, just to be topical, and he said, the last time I saw him was I think 5 months ago, and he said, so remember how you told me that this wasn't going to happen? Because now his mother is dying in Yemen, and he's afraid to go back and visit her because he's afraid that he won't be able to come back here, which is probable. All right, so, and then for me, as an internist, the most complicated part to learn and understand has been the sort of socioeconomic aspect of things. And there's a lot of people who are speaking today and a lot of people in this room for whom this is not as counterintuitive as it was for me. For me, the medical and psychiatric stuff is pretty straightforward because as a physician who works, especially one who works in a county hospital, I'm used to the fact that the prevalence of medical and psychiatric disease are differentially distributed in ways that systematically afflict people who are on the wrong end of power hierarchies, right? Whether it's because you're part of an ethnic group or you're poor or whatever. The intricacies of how that plays out in terms of your access to service, to housing, to social support have been a real eye-opener for me over the years. The distinction between refugees and migrants and asylum seekers has already been raised, as has the fact that refugee resettlement is not a bed of roses by any stretch of the imagination. But people who come here without any kind of status, without any kind of infrastructure, have no guarantees and depending on where they are, geographically, just in terms of counties and zip codes, may have no guaranteed access to any kind of health or especially social resources. We have a really vibrant indigenous Guatemalan and Eritrean communities in Oakland specifically, and so if you happen to come from one of those groups and you walk here, you often find yourself in a place where there's people who speak your language and on whom you can to some extent call for assistance with employment, housing, stuff like that. But I think every urban community in the United States has people who have come here under enormous pressure and possibly at threat of their lives from other places and have ended up in places where they don't have that kind of community, and they also occupy a legal status or a lack of legal status that means that they don't have access to services. So the case that I always think of when I think about this is one of the things that I do in our human rights clinic is female genital mutilation evaluations, because if that's been done to you, there's not really any further questions at the asylum court, at least in the San Francisco asylum court. So those are generally pretty straightforward in terms of evaluating people. So a lawyer sent me this lady from Guinea, and I thought that was what was going on. So I did my exam, and I said, yeah, she has WHO type 2 FGM, done, signed, gone. And the lawyer got back to me and said, so the problem here is that nobody wants to deport this lady to Guinea she got married to a South African guy, and then he took her to South Africa where he abused her sexually and physically for the succeeding 10 years. And she's just escaped from that situation. And so despite the fact that she's not a South African national, they want to deport her back to South Africa. So she had a really good lawyer, and I had very little to do with the fact that she ultimately got asylum. But all these cases take forever. And so this poor lady who's from Guinea mainly speaks French and has no contacts in the area was in the East Bay during the coldest winter of the last 5 years, supporting herself exclusively by part-time and totally unguaranteed work in an African hair braiding salon, which was unheated, where she slept on the floor at night. And this went on for months. And it was, obviously it was much worse for her than it was for me, but I felt terrible because, here I am, a doctor in a county hospital who's got some kind of social justice mission, and I'm trying to marshal the resources that I usually have for patients like this in terms of social workers and therapists and whatever. And the main barrier was that she was an asylum seeker in process and was just not eligible for anything. So that story ended well, but they don't all. And I think it's a barrier for primary care clinicians who don't have training in that or specific experience of it to imagine the kinds of things that people have to contend with. And that's where I think with all of these things, from the medical to the social to the psychological, what's so important is curiosity and asking people about about the barriers they're facing and the things that they've been through. One of the articles in the book that you have is one I suggested about barriers to divulging trauma histories among refugees. And what's fascinating about it is the informants of the article overwhelmingly said that the single greatest barrier to them divulging the history of their trauma is that the clinician never asked. And that applies to all the things that I've talked about. So the last story I'll tell in my 3 remaining minutes is very topical and speaks to not a new but a renewed set of difficulties that face this particular group of patients. So I've been taking care of a woman for many years who's undocumented from Mexico. Early in our relationship, her son was deported, which was an enormous trauma for her. She was not. And she's got terribly controlled diabetes. That's been her main problem the whole time that I've been taking care of her. I haven't seen her for 3 months, and I think I know why. She came to our clinic to an urgent care slot with chest pain and changes on her ECG. So she's having a heart attack until proven otherwise, and that's one of the presenting symptoms of heart attack is sudden death, right? So this is a medical emergency. The resident who saw her, who's a native Spanish speaker, called me and said, I'm seeing your patient, and I think she needs to go to the emergency department, but she says she's scared that if she goes there and she divulges her information, she'll be arrested by ICE. And I said, well, reassure her from me. I've known her for years. She's safe here. It's okay. We don't share information with them, and they're not here right now, but she needs to be seen because it's an emergency. So 2 hours later, I go to the emergency room to see what's going on and how she's doing, and I look on the board, and it says, called 3 times, left without being seen. And I haven't been able to contact her since. That was 3 months ago. So we have to be, as clinicians, aware of those issues as well and find sensitive ways to inquire about them, and that's one of the reasons that this discussion today is so helpful. It's because we've brought together a lot of people who know a lot more than I do and have a lot better ideas about how we might approach those difficult and sensitive issues without re-traumatizing or scaring people. So I just want to conclude by thanking everybody for your attention, thanking the organizers of this event again, and saying that I think it's more important now than ever that the clinicians, people who are on the front lines who are working with migrants and refugees, cultivate a humble, solicitous, and caring curiosity about these medical, psychiatric, and socioeconomic barriers and complications to care that I've been talking about. And I think it's also vital that we recognize that given the current changes in federal policy towards migrants, refugees, and asylum seekers, we all face an increasingly weighty burden of proof, which I think was discussed eloquently in the last panel, to demonstrate to these people that we're on their side, and a grave responsibility to advocate on their behalf. Thanks.